All right, so I am so supersonically thrilled that we have Dr. Victoria Stanhope this morning. I've actually known Victoria for probably 25 years at this point. Yikes, we're getting older. Anyway, Victoria is a friend, she's a colleague, and she is an impressive and prolific scholar and someone I've just really admired from the day that we met at University of Pennsylvania. So just super excited today. Victoria is an associate professor and director of the PhD program at NYU, and she's also the author of the 2018 text on social work and integrated care, which is pretty amazing. Her professional interests are in mental health services, research, and policy, and so many areas of research, but her specialization areas are recovery, person-centered care, and primary and behavioral health care integration. So holy cow, we're so impressed and so excited. And I'm just going to turn it over to you.
Okay, thanks, Julie. I'll never live up to that introduction. But yes, I am also a fan of Julie. She's been a friend and a colleague, yes, for a while. And it's been great to see all that you've achieved. So, and great to see all of you. And I know that you're all involved in this work of thinking about integrated healthcare and how we can change the way that we deliver healthcare. So I'm gonna give you an overview, a sort of whistle-stop tour through how we came to think about that we needed to change this healthcare system that we have in the US, and how it led to thinking about integrated health and social determinants of health, and some of the skills and knowledge that we have as providers. So this has really put our work on the map. So this is, yeah, the background, both practice and policy sort of combined. And this is a good day to think about policy because this is was a very significant day yesterday, even though not resolved, and of course significant in terms of we will try to have a transfer of power today. So, and these will impact the future of healthcare reform. So it feels like an auspicious day to talk about this. So, hopefully you can all see that, everybody see that. Is that good, Julie? Yeah?
Yes, looks good.
Okay, great. So let's start at the root of the problem. Actually, let me just back up and just give you the larger picture. So achieving integrated healthcare and nurturing a new generation of healthcare providers that are you. So let's start with, and really this is the early 2000s. So obviously healthcare has been evolving ever since we had a social welfare system in this country. But I think in the 2000s, it reached a tipping point, a real crisis in terms of the failure of our healthcare system. And if you look at this chart, which is from 2007, and comparing us to peer countries with different healthcare systems and how we are doing compared to them. And how this has often been termed is we have a very poor return on investment, because if you look at how we rank the US in that last column, we are pretty much bottom on the majority of these key healthcare outcomes. But if you look at how much we're spending per person, it's twice as much, if not more, than these other countries. So the crux of the matter is, why are we spending so much money and having such poor health outcomes? Probably the most important health outcome is long, healthy, productive lives. And as you can see, we were ranked in 2007, 7th, so last. So people not leading long, healthy, productive lives. And this is an illustration of this. This is the Institute of Medicine brought out this report in 2013. Very, very sobering. And this is particularly focusing on women. And if you look at this, the most important thing to look at is the comparison here. So the gray line being, again, peer countries, similar countries in terms of middle, upper income countries, and the United States in terms of women dying before their 50s. And as you can see, again, nearly twice the rates for all causes. And you can see in that category, non-communicable diseases, which are the chronic diseases along with cardiovascular disease, that the US is doing worse and losing lives to these diseases. So, and actually this report, I'll read you a little clip from that. The panel was struck by the gravity of its findings. For many years, Americans have been dying at younger ages than people in most all other high-income countries. This disadvantage has been getting worse for 3 decades, especially among women. Not only are their lives shorter, but Americans also have a long-standing pattern of poorer health that is strikingly consistent and pervasive over the life course. So, what are some of the underlying reasons for these very poor health outcomes? Well, one of the striking facts about this group of people who are experiencing poor outcomes is how many of them had comorbid illness. And I know that a lot of you in your field placements see this, which is that people have particularly co-occurring mental disorders and medical conditions. So if you look at this, these 2 circles, and then you look at that overlapping area, and you look at the smaller circle, which is all people with mental disorders. So that's 25% of the adult population. So that's both severe and mild. And then you look at how many of them also have a medical condition, and that's 68%. So that is a very high figure and leads to mortality. So recent studies, again around this time, well, not recent now, but in the early 2000s, showed that people, particularly with severe mental disorders, were dying at 25 years younger than the general population. And that study that came out in 2006 was a real sort of alarm bell, and I think was a huge contributor to us changing the healthcare system. So, and this again shows the high, the fact that many of these people with comorbid conditions with substance abuse or mental illness are ending up in the hospitals. And that's what's driving that cost. That's what's driving that $7,000 per capita cost, twice as much as other countries, is that people are getting their healthcare in the ER and in hospitals, which is not a good place, the most expensive and not a good place for people with chronic conditions. So if you look at this chart, you can see and these are the people that were considered high risk of rehospitalization in New York City. And you can see that 72% of them have substance use and 66% mental illness. And then you can see, if you move along, some of their rates for hypertension, diabetes, asthma, COPD, which are the very common comorbid medical conditions that this group have. So, and as I said, this is very expensive. So if you look at Medicaid spending, which is the major funder for people with mental illnesses and obviously low-income populations, you can see that it's actually 5% of that group are generating 54% of the costs of Medicaid. So if you can target them and help them you can help them keep out of the hospital. You can save an awful lot of money. And this is why the majority of the metrics and the goals for healthcare reform have focused on reducing hospitalization. So, and this shows, this actually goes back to 1998, but again was a very influential study that was actually done at NYU, because New York State, even though is good in terms of healthcare and healthcare services, it was treating more people in the ER and the hospital than any other state, and that was generating huge costs. And if you look at this, you can see that the huge majority of people should not have been in that ER to start with. 41% non-emergent, meaning that they didn't even have problems that warranted an ED visit. And then we have some that were treatable in primary care. In the non-emergent group, you're going to have a lot of mental health problems. And then some had reached the stage where they needed emergency care, but it could have been prevented. So you only had 17% of people who really actually should have been there. And the rest, it's a very ineffective way of helping people. So that kind of leaves us with this. And this is where I think finally there's reached a point in the late 2000s that many, including the providers, felt that we needed to do something about it. The problems that we were seeing was lack of access. So we had 48 million people without insurance and resources. So they often went to the ER to get care. That still hasn't stopped, but it's much better. Overuse. So the problem is some people getting too much, really high cost care that they didn't need. And then some people not getting what they need, and particularly not getting prevention, early intervention, primary care, or behavioral health services, all ways to keep people out of the hospital, and medical errors. So we have a very fragmented system that has a myriad of funders, a myriad of ways of delivering public and private, and it varies from city, it varies from state, and all of that means communication is a nightmare, and coordination. So these were the sort of key problems that healthcare reform was going to focus on. And obviously, these huge costs. And you know, I think when you talk about cutting costs, people get worried, rightly so, because they think, well, maybe, you know, people are going to get less healthcare if we focus a lot on healthcare. But the truth was at this stage that about 30% of healthcare costs could be saved without impacting quality. So spending more wasn't generating more quality. And so saving money doesn't necessarily impact, doesn't actually make quality less. In fact, it may improve quality. So how are we going to do this? How are we going to shift a system that has become so ineffective? So really a new approach, shifting away from the medical model and thinking about prioritizing other parts of healthcare that will really serve people, particularly people with chronic illnesses. So it's a new approach, but I don't think it's not such a new approach from the social work perspective and other professions who focus on the holistic person, who are aware of all the environmental factors, all the factors that play into how the person you're working with is doing. So a new approach, but maybe not a new approach for us. So have to shift the resource allocation, turn it upside down, and start putting the majority of our money into prevention and primary care. We, as a system, it's oriented to acute care. All the money is at the hospital level, the specialized care, the surgeons, the high end, you know, so we're very, very good at keeping people alive right at the end of life, but we are awful at preventing them getting to that place in the first place. So prevention and primary care are what we need to shift money to. And so how do we do this? So the triple aim was developed really to give us an overall sort of blueprint for healthcare reform, like what are the overall goals of this system change? And so it's the three primary aims, which is improving health outcomes, better health for the population, better care for individuals. So that's the experience of care. So we need to improve how people experience care. And then we need to lower costs. But if you try to do one of these things and not the other two of these things, you probably will make the other two worse. So the whole logic of the triple aim is you have to achieve all of these simultaneously. And so that prevents the fear, you know, which I think we saw in the 1980s and the 1990s of managed care, where they saved money, but they actually also decreased quality. And we saw people getting less services, less good services. So this is a way to ensure that that doesn't happen, that any savings that we get are not at the expense of the quality of care or people's health outcomes. So as I said, increase preventative care. Yes, keep people out of hospitals, keep them well in their communities, promote early intervention, improve the coordination of care to deal with that fragmentation problem, use evidence-informed care, or probably you're all talking about evidence-based practices. So use data to inform what we do, decrease overuse and underuse of services, and reduce error rates. So this was the sort of logic, the blueprint behind healthcare reform. Oops, sorry. There we are. So a key part of that coordination is integrating healthcare. So we have split the mind and the body within our healthcare systems, right up to the federal level, where we have different departments for who deals with substance abuse, who deals with healthcare, who deals with mental health. And that bifurcation exists all the way down to the services that you deliver. How many of you have said, well, I can't deliver this mental health service until this person goes into rehab, to detox, that we separate out these three parts that are highly related. Yes, and I think all of you probably in your practice have experienced that yes, if somebody's depressed, their healthcare is going to be worse. If their healthcare is bad, then they get depressed or they get other mental health problems. So we know that the two are interrelated. So why do we pull them apart and treat them separately and have very little communication between those two treatment settings? So we saw the integration of healthcare, and this really came about before the Affordable Care Act. This was really starting to happen in the 2000s and it was being mainly driven by costs and the thought that healthcare systems had to do something differently. So, so we were starting to see the emergence of healthcare models that tried to integrate physical and behavioral health care. Make it person-centered, make it holistic. So that is what you see. You see the whole person. You just don't see a little clutch of medical symptoms or a little clutch of mental health symptoms. You see all of them. Population-based care, which I think is particularly in social work, we are still fairly individual focused. We treat each individual who comes before us and think about what they need. But this is a way to say, is there a group that has a shared need? And if we think about treating that group, it will be a much more efficient, effective way, like asthma, like diabetes. So we're seeing population-based care initiatives within integrated care. And again, data-driven care. Can we use data to inform what we're doing? And in real time, like really know how people are doing based on measurement. And then again, evidence-based care. So using interventions that we know are effective. So, and team care. So if we're going to get that coordination, if we're going to get that integration, it means that we all need to work really closely together. Again, I think that's something that social workers have historically worked on teams, other disciplines. I know some of you from counseling and nutrition that you've worked on teams, but really much more emphasis on teamwork, and not just having a team and each do their individual work, but really share your expertise, collaborate in a really meaningful way. And then the chronic care model. So this came out of the 1990s. Wagner developed this, and this was the antidote to this acute-based care system that we have, that we just wait till somebody has big problems, then they come in the door, we put them together again, and then we send them out and just hope they don't come back again. If you have a chronic illness, you will come back again. And what you're doing when you're out in the community is really important, and it can often prevent you coming back into the hospital. But we pay little attention to that life beyond the clinic walls, and we episodically, so you just keep showing up for asthma problems, and we keep treating these acute symptoms and not think about how to prevent and manage this illness. So this model is a way to change that dynamic. So again, driven out of if you're going to really think about, it's important what people do in the community, all that time that they're not in your healthcare system, you have to have somebody who's engaged in their care. So that activated patient is a key part of that. And then the team who are proactive, not just waiting for people to become sick and then dealing. And then healthcare systems. So you change the delivery systems, which we're going to talk about. You provide more decision support, both for clinicians and the people receiving the treatment. And you communicate better, which means technology. So now we have technology which can allow us to communicate and to coordinate care on a different level. So that is a key part of this movement now. And then you worry about what's going on in the community and think about how do people manage their illnesses when they're out in the community. And again, this is where social work comes in, because we know how to do that. We understand communities, we move in communities, many of us do in vivo community work. And so this is something that is embedded in our practice and something that we can really bring to this new way of healthcare. We also understand the social determinants of health. We may have called it person and environment, psychosocial factors, but now this language is key to shifting the healthcare system. And it is a recognition that healthcare is only one, and actually surprisingly small part of what keeps us healthy. If you see here, 20% of your health is determined by the healthcare you receive. The rest of it is where you live, your job, your neighborhood, and your health behavior. So that's where the nutritionists are so important. Yes, so if we target, and this is 80% of what determines whether you're healthy or not, we can make a big difference in terms of health outcomes, rather than focusing on healthcare, the sort of end point of keeping people well and putting all our money into this very expensive part of the healthcare system. that actually has a smaller impact than if we address behavior, where people live, and the larger structural factors that really shape our well-being every day. So social determinants of health, but as I say, I think this is not news. It's not news to social work, but it has now really come into focus in terms of healthcare. So
watch this and other Frontline programs.
So I'm going to show you a short video. This is from PBS. It's Dr. Hotspot. I'm going to show you a couple of clips. If you want to watch all of it, you can just, it's very easy. It's very available. And this is about Jeffrey Brenner, who really a doctor in Camden, New Jersey, which I'm sure some of you know, nearby to where you are, who really put on the map this idea of we need to focus on that 5% and think about their whole lives, not just their medical conditions or their mental health conditions. So here we go. And I'm going to jump about a little bit within this. Could people hear it? Julie, could you hear it?
Yes, I can hear it. Yep.
Yes. Okay, good. All right. Okay. All right. Here we go.
Camden, New Jersey sits in the shadow of Philadelphia. It's a city that seems in a constant state of peril. Poverty here is rife. Unemployment is double the national average. Public institutions are in crisis, or, like the local library, simply shuttered. It's officially one of America's most dangerous cities. But Camden may also be the city to help solve one of America's most intractable problems, lowering the cost of healthcare. Brenner then turned that raw information into visual information.
So this is a map of the city of Camden, and this is looking at cost data. So the red areas are high cost hotspots. These are parts of the community where people who have more than $1 million in payments to the hospitals live, and this is over a 5.5-year period.
So here you pulled out the two most expensive city blocks.
Yep.
But you found in your community there are two buildings
that
are the most expensive places.
That's exactly right. So the building on the bottom, Abigail House, is a nursing home. And the top one, Northgate 2, is an apartment tower with elderly and disabled people.
$83 million in bills.
That's right.
It's probably more than the cost of the building.
Yes, yep.
This being America, where we all demand the best that medicine can offer, you might assume that at least for the money, the residents were getting good care. But Brenner found the majority of the care for chronic diseases, from asthma to cancer to diabetes, was being done in the ER, not a good place to treat chronically ill patients. Treatment was not coordinated, follow-ups were not part of the plan.
It was really obvious in the data that the most expensive people were getting terrible care. And I knew them, so I'd walk in the exam room and say, Mrs. Rodriguez, I haven't seen you in 3 months. Where you been? Well, I've been in the ICU for a month and a half. I've been in the hospital for another couple of weeks. And I'd said, well, what happened? And she'd say, well, I'm not really sure. A lot of doctors came in the room. They never really explained anything to me, but I've got this whole bag of medicine. So American healthcare doesn't do a good job taking care of sick people. The way we built our system is really a system that's very hard to access. It works well for the average patient, but if you are blind, if you're deaf, if you're disabled, if you're in a wheelchair, if you don't speak the language, if you're developmentally delayed, if you have a complex mix of illnesses with many providers involved, the whole system starts to break down.
Brenner's big insight was to use his data to target the sickest and most expensive patients in the city. In 2007, supported by small grants from foundations, he put together his team of medical hotspotters.
Hey, Anjanae, it's Kathy Jackson giving you a call from the Coalition. I was wondering if you had a chance to do your blood glucose logs.
The most visible part of the Camden Coalition of Healthcare Providers are these nurses, social workers, and medical assistants.
I think it's also important to show that he was really going all over the state.
Yeah, wherever.
3 years later, his team of troubleshooters has sought out and organized care for more than 300 people.
Make sure we have transportation that's going to be able to accommodate a disability.
When I visited, Kathy Jackson was making a house call to one of her most challenging patients, Derek.
Do give me the briefing on Derek, because I haven't met him yet.
So Derek's in his 30s, and he has seizure disorder.
Okay. Yeah.
And then his other problem, which gets him in the hospital most of the time, is asthma. It's always an issue. He's always wheezing, and the house it's dirty, it's dusty, roaches, all kinds of triggers. So we took a contractor there, and the contractor said that he really wouldn't want to be liable to fix it up because he's afraid it would actually crumble.
So Derek, and if you want to meet Derek, then just go to Dr. Hotspot, is a classic example of his neighborhood, his housing particularly, is what is exacerbating his asthma. So rather than him, and he had multiple hospitalizations, keep going back when he had asthma attacks, why don't you deal with the housing, which is what Kathy was doing. So yeah, the new approach using social workers, nurses to address these social determinants to save the healthcare system a huge amount of money and provide people with a better quality of life. So thinking about this, this was actually a report which I think you may have read, hopefully, which was driven by the social work profession to really think about what does it mean to integrate social care into the delivery of healthcare. So that is really realizing this social determinants approach and thinking about the ways that social workers work with community organizations, work to see people holistically and address other aspects of their lives that can actually keep them healthy. So, and this has been a sort of important way to sort of not repackage, but represent what we do as social workers and showing the niche that we have in this new approach to social work. It would have been very nice if we had called the title, if we'd named this specifically for social work. Not sure why that didn't happen, but it's certainly a step in the right direction. And then this is another important development, which is coming up which is developing screenings for social determinants that can be administered in healthcare environments. So, and you can see if you look down all the different things that this measure called PREPARE, which is now being fairly widely utilized, what it measures. So it pays attention to education, employment, transportation, neighborhood, safety. Again, a little like a psychosocial assessment, but this has really sort of put it on the map. And then if you assess for all these problems, then you need to be able to address them. So then you need social workers and other related professionals who can really address benefits and transportation and neighborhoods. So this is a really sort of concrete way of shifting the focus within the healthcare system. So this is a big shift. It's a big shift from the traditional medical model. It's trying to shift the paradigm from acute care to preventive care and bring in all these concepts such as population-based care, social determinants of health. So how do you do that? You need a really significant piece of legislation to start to address that and to really provide both mandates but incentives for healthcare systems to change the way that they work. So we saw the ACA, and I'll quickly, we'll quickly go through the drama of the passage of this legislation. So amazingly, it was 10 years ago that the Affordable Care Act passed, the first national healthcare legislation that we had seen that addressed universal healthcare. Yes, so before we had just focused healthcare policy on individual groups that we deemed worthy. FDR tried to pass national healthcare legislation, national insurance. Clinton tried to pass it in the 1990s, and finally Obama took it on in his administration, and it was not easy. Yes, so you really actually could not have, it read like a movie script, how this piece of legislation finally got passed, and the drama is not over, as we know. So it generated a lot of love, a lot of support for Obamacare, and a lot of virulent hate. And there you can see the communist symbol, that this was socialist medicine. And we had a lot of rhetoric, black humor. This was Sarah Palin saying that the Affordable Care Act is going to lead to death panels for Medicare patients. And we had some tragedy as well, where the bill was set to pass. Ted Kennedy, one of the major proponents of healthcare reform, tragically died of brain cancer just when the vote was ready, that vote, and then was replaced by a Republican senator from Massachusetts who didn't support it. So it was back to the drawing board, back to a lot of politics. And in the end, after much struggle, much lobbying by Nancy Pelosi, who can be seen as responsible for this bill passing as Obama, finally, it was signed into law. And if you have an opportunity to read Obama's memoir, which is just out, you will see that he had a very large martini after he signed that bill. And I think much deserved. So I recommend that you read this. So then we had then there was a sequel. We had courtroom drama. Yes, so major challenges to the Affordable Care Act. The most significant in 2012, where they challenged the mandate, saying that you could not force people to purchase healthcare insurance, which is the mandate is that you will pay a tax penalty if you don't purchase healthcare insurance. So it squeaked through and was upheld with that. But we are seeing many more legal challenges, the latest of which was heard just after the election, and was considering whether healthcare, the legislation can stand without the mandate, whether it is still valid. Looks like from the Supreme Court Justice's discussion that they will continue to uphold it, but it is constantly under threat. And has now experienced 4 years of the Trump administration. So here, in Trump's usual very articulate way, he talks about his decision to get rid of the mandate. So no longer do people get a tax penalty if they do not have healthcare insurance. So that was considered to be one of the key parts of it. It does seem to have survived, but probably not as well as it did function with the mandate. And in terms of where we're going with healthcare reform, whether now under a Biden administration, we can see it strengthened actually, and some of these attacks and regulations, some of them will be restored under Biden, but some of it will need legislative action. And I think what is happening right now with the Ossoff election will determine whether we can see legislation that can strengthen the Affordable Care Act further. So we've seen Trump get rid of the mandate, stop subsidies for insurers to go into these marketplace exchanges, and enforce workplace requirements for Medicaid, and cut the funding to publicize the enrollment and help people navigate enrollment. So all of that has undermined the Affordable Care Act, and some of the positive effects that we saw have decreased. So, but let's go to the sort of substance of what this thing does, particularly what this bill does, particularly in terms of delivery system reform. So much of the talk about healthcare revolves around insurance reform, coverage expansion, which are really key parts because people need to have access. But a lot of the integrated health part falls within delivery system redesign and payment reform. That is where the system is being reconfigured to incentivize more integrated care. So what they did was not mandate people to adopt these integrated healthcare models. What they did instead was incentivize them. So provide through the Centers for Medicaid and Medicare Services funding for demonstration projects to show effectiveness. And one of the primary models, and this is a system-wide model, is accountable care organizations. And these were targeted towards Medicare recipients. And it was a way to, in the same sort of logic of managed care, which is that healthcare systems take on the risk for the cost of care. So they have an incentive to keep costs down, to be more efficient, to be more coordinated. And that coordination comes if you have a system that is self-contained. If you have clinics and hospitals and medical homes, which is the primary care part, all in the same system, then everybody knows what the other part of the system is doing. And the quality of care is much better. We've now got 480 ACOs, and I'll quickly, we had a bit of time. I may actually just move over this accountable care organization video, but I'm absolutely happy to share it with you, and so you can watch the video on your own time. But as I say, basically, it functions like Kaiser Permanente, these sort of completely self-contained healthcare systems that also take on the risk. They take on a set amount of money from Medicare, and they say, okay, we're going to deliver you care. And it gets away from the whole issue of fee-for-service. Because if you get paid for each individual healthcare service you provide, you have an incentive to provide a lot of services, even if people don't need them. Whereas if you are responsible for the cost of that, paying that out, you will think much more about the services that you provide. And that is sort of the logic of moving away from fee-for-service to a more managed care environment, but doing it with a lot more focus on quality than I think we saw in the 1980s and 90s. So, and then primary care, we really, really want to step up primary care. So, and how we make primary care more effective is to think about meeting the needs of the whole person within primary care, not just referring people out, and often they don't get where they need to get. That is especially true for behavioral health. So have a behavioral health specialist in the primary care setting. So these medical homes are structured around the primary care setting, but they have a whole team of professionals and social workers, behavioral health specialists, depression specialists, and really paying attention to people's mental health. So the big studies of this collaborative care model, which is what it's called, targeted particularly older people, it's the impact study, and they had the most amazing results with 50% reductions in depression and compared to usual care, and people maintaining their health. So it's been a very influential model, and you're seeing it now more and more. So team approach, collaboration with other providers. So you have networks where if you do have to do specialty care, you're networked with them. Again, use health information technology and focus on self-management. So have people like nutritionists, people who can think about how people remain well in the community. So patient-centered medical homes as are often embedded within accountable organizations. So, but integration, there are many different models, and there are health homes, which some of you may have experienced, some of you had your placements in. So health homes are particularly targeted towards people with chronic illnesses and severe mental health problems. So they operate a bit like those hotspotters. They are just a team of providers who are coordinating care and keeping a small group of people who are at risk healthy, doing many of the activities that you saw described. So, but there's a continuum of integration that you can see in all organizations. And this is from the HRSA Center for Integrated Solutions, and shows you the whole kind of spectrum that you can see, which is completely separate systems, minimal collaboration, to fully integrated, which means that you may have a mental health clinic co-located, yes, with a primary care clinic, and completely shared systems, shared care plans, shared teams. But there's a whole sort of, shades of gray in between. And sort of part of the complexity of this and trying to figure out whether it works is the issue of how complicated it is and how many different models they are. But all of it is trying to improve the coordination of care by teamwork, by digital, by health information technology, yeah, and having people like social workers be able to think sort of beyond the clinic walls. So how do you incentivize these? Well, you incentivize it by money. So all settings, yes, they deliver the services that they get paid for. They don't always deliver the services that actually people need. So there's been a mismatch in terms of incentives, which has made us put all our money into acute care. So you have to incentivize these new ways of delivering care, and you do it by not paying for something that doesn't work. So as I say, in fee-for-service, every test that was requested, then you would be paid for. So the incentive was just to request every test, whether it was really needed, whether it really made somebody, whether it led to better outcomes. You did it because you were paid for it. So value-based purchasing is about purchasing services that are shown to be valuable. Yes, not just about volume. So it gets fairly complicated, but this has sort of transformed the way that hospitals function, because this is to avoid people coming back in when they did not need to. So now you will only be paid for a set of services that are appropriate for whatever complaint that you have. And you will be paid for 30 days for that. And if you have an inpatient that was avoidable, you will not be reimbursed for it. So that is a huge incentive for hospitals to really think about the care they get in the hospitals and aftercare. So now this makes discharge really, really important. Who does medical discharge? Often social workers. So now we are on the front line of dealing with how do we keep people out of the hospital in terms of where are they discharged to, what's the support they have, what's the quality of their housing, can they access their medications, and all of these. So this is, I think, this is the future of healthcare. It will happen within the private system as well as the Medicare funded systems and the Medicaid funded systems, that we will see these much more integrated systems. And I think probably some of you have already experienced that, maybe even in your own healthcare. So part of another important is if you save money, that you should get some of that money back. If you save the overall healthcare system money, you should be able to get money. So Medicare is now sharing savings with high performing settings that have managed to bend the cost curve. And also, it's really helpful for people to get money ahead of time, because then they can create infrastructure, they can create innovation. But if you are always having to wait 6 months and sometimes longer to be reimbursed, you cannot do that type of really important sort of investment in changing the way that you deliver services. So a lot more prospective payment systems. But to get that money, you have to show that you're doing prevention, you're doing early intervention, you're doing care management. So we're seeing more and more these strategies, and pay for performance is really important, because that is showing that your outcomes are better. Yes, so you get paid only if a person does better, if you promote wellness, if you keep people out of the hospitals, if you show on indicators that you are improving somebody's health. So that's something we have to really, really think about in terms of social work. How do we actually impact people's outcomes? Sometimes we think about the process of care, but we really have to be able to translate what we do in terms of that. So 10 years on, yes, definitely saw improvements in terms of coverage. You can see that, but it's now creeping. It's actually now creeping up, that we're seeing more people uninsured, and that's due to some of the attacks on the ACA from the Trump administration, but it has really made a difference. And it's really made a difference in terms of populations of color who have experienced higher rates of uninsurance, part of healthcare disparities. So you can see significant decreases among Black population, among Hispanic, in terms of uninsurance. And most of that has been driven by the expansion in Medicaid. That is where people have really benefited, and some states have done that expansion and some states have not. And we have seen a decrease in hospitalization. And that has promoted cost savings within Medicare. In terms of these integrated health models, more complicated in terms of the positive effects of accountable care organizations and patient-centered medical homes and health homes. Really complicated to figure out the impact of these complex models, but some signs that they have had a positive benefit. And then, so hopefully here to stay, yes, the ACA has weathered many attacks. The longer it's here, the more chances is that it will stay. Because with any social welfare benefit, the more people get it, the longer, the more hard it is to take away. So, but then March 2020, and we faced the greatest public health crisis for a century. We're living this now. And so this is probably another inflection point for the healthcare for our healthcare system in the United States. It is, it has shown that many of the problems that I talked about right at the beginning of this lecture are still there, and it has brought them into great relief. So we're still, we have faced some of the greatest, well, we have, the US has had more mortality than any other country in the world. We're right in the midst of it now. We're in a surge, and these are the very scary forecasts from the CDC going into January. So huge mortality, and that mortality has been disparate and shown the underlying inequalities that we have in this country. So hugely disproportionate impact on Latino and Black populations in terms of illness from COVID and death. So still the disparities, the health inequities, we are still in the midst of this, and it has put it in more relief, the suffering that people have experienced and will continue to experience. And then we are experiencing a huge economic freefall as well, which, if we connect that to the social determinants of health, will impact people's health. In some ways, the most immediate way is people have lost their jobs, so they've lost their healthcare coverage. So the continued linking of employment and healthcare in this country has meant that people are vulnerable, and when they lose their jobs, they lose their healthcare. And so we're seeing food insecurity, we're seeing housing insecurity, and of course, we're seeing huge mental health problems, huge increase in opioid overdose, really scary rises in the rate of from March to June as a result of COVID. So it's a tsunami that the healthcare system is dealing with now. And in terms of solutions, again, we deal with a fragmented system that is struggling now to get out the vaccine, because we don't have a national healthcare system where everybody has, you know, it's a documented provider. So it's very hard to track and coordinate. And at this stage, we have no federal plan. That may change. So what went wrong? Can we build back better? I think a lot of what went wrong, there are many, many reasons, and many of it has to do with, of course, the deep ideologies that continue in this country around individualism and freedom and capitalism, and how hard it is to address a public health threat when we feel so divided, when we prioritize individual freedoms over the collective health, but also a system that just wasn't ready to handle this. So we have to think about how can we build back better. And part of that is continuing to build, I think, the good work that has been done in terms of thinking about the social determinants of health, thinking about these upstream factors within addressing upstream factors within healthcare. So, and these are all the ways that we can do in terms of each of the social determinants. So, and a lot of that has to do with policies and factors that are, as I said, beyond the clinic walls. And this is within communities, with relationships, with community engagement, and in the healthcare system, improving quality of care. But a lot of these things are what we are trained as social workers, as counselors, as nutritionists, we are trained to address these issues, these broader issues, thinking about people holistically. So what can we do? I think, and this is you're in the midst of this, and you're being very well trained to think about this, but we have to think about translating our value, yes? So social justice, key part of social work. So think about it addressing health disparities or health inequities. I think health inequities is now being used more than health disparities. So that's the terminology we should use. How do we address health inequities? The dignity and worth of the person. So we provide holistic care, we provide person-centered care. That is a key aim of healthcare reform. We empower people to make their own decisions. So the importance of human relationships, and this is sometimes the value of what we do, but it is hard to translate that into healthier people. How does that how does that actually happen? So, but we can talk about engagement and activation. These are the words that are being used now in terms of thinking about chronic care and how do we have people be really active in their own healthcare. And then, as I said, person and environment, that's something we've always, has always been absolutely core to social work, but now we can translate it to social determinants of health. So what are those roles that we do, those that work in the community, and how does it address the social determinants of health? And we know how to do all these things, which are now more needed than ever. So we have to keep doing them, and we have to translate them into this new healthcare environment. And then we need to say how we are contributing to these three aims. So we have to show our value, something I think sometimes social workers don't want to think about so much, but we really, really have to think about translating our work. So, and we have to train the next generation of social workers, which you are all doing at Westchester University MSW program. You're doing amazing work in terms of these multiple HRSA grants, which are the first time that HRSA has specifically targeted money to social work training, which is why it's very exciting. And it is great that your school is leading the way, particularly focusing on opioid use and substance abuse, but thinking about it in integrated healthcare settings. So this program is really helping us place students in integrated care settings and building on what the core social work knowledge, but also learning how to apply that in these new healthcare environments, which means, learning about health information technology, learning about healthcare screening. It does mean that we need to learn new things, but also apply our core knowledge. So, and I think if hopefully we keep doing that work, we will produce great healthcare providers. So thank you. Thank you. I'm going to stop there.
Oh, wow. Thank you so much for your excellent presentation, Victoria. That was really, really amazing. I wish we weren't on Zoom so that we could give you this joyous clapping and cheering sound, but that was extraordinary. I can't wait to rewatch the video that you let us make. So thank you so much. Yes, I'm going to give you one of my little clap reactions too. And I feel like this is such a special day because it is an auspicious day in American history that we have sort of, the potential for another, like you said many, many times in your presentation, that we're at an inflection point. We may, in these next 2 years, be able to make some real, true policy changes that affect the lives of individuals and populations and right some of the wrongs that we are contending with in healthcare. So it's a very, very exciting day. And wow, for a whistle stop tour, like That was a great whistle stop tour. I feel like we got a history lesson and a policy lesson. And boy, there's no one better than you to hear sort of the fits and starts of some of the efforts that have been attempted in American history to really address these, this bifurcated system, these siloed ways of working with our client populations. And this was just thrilling. So I don't know, Victoria, if you have a few minutes, maybe, I don't know if there are some questions. Would you be open to sticking around for a couple of minutes? Every time I thought I had a question.
Yeah, no, I'm fine to say. I mean, just to say, I mean, just one of the sort of, is, when we think about, we may have an opportunity to address some of these structural, really upstream, yes, structural issues. But right now, a lot of what we're looking at is within the healthcare system. So in a way, we're medicalizing social problems, but it's better that we deal with it there than deal with it, than deal with it in the ER, to think about housing when we're thinking about delivering healthcare. But in some ways, it is the failures of our overall social welfare system and our very unequal society that is driving the healthcare system to have to think about these things. So I don't know. Yeah, maybe if it's good news in terms of these elections, we may see an opportunity for more structural legislation.
Yeah. So anyone have like a burning question for Dr. Stanhope that did not get covered in the presentation? I feel like, I was constantly you were answering questions as we were kind of moving through the presentation. Anyone feel like they've got something that you're just dying to ask or find out about? Jaja?
I don't have a question per se, more so just curious in the sense how different states like Pennsylvania and New Jersey have different laws regarding Medicaid, like plays a major part in medical or even service provided for individuals. So I wish it was like more universal, like uniform, that everyone can seek the same services and treatment.
Yeah, absolutely. Yeah, so, I think Pennsylvania has its, yes, it expanded, and New York has obviously expanded Medicaid, and that really, really made the difference. But you're right, so many states chose not to, even though 95% funded by the federal government, they still chose not to expand Medicaid. And that, I think, has been probably the most positive impact is that expansion, especially for single low-income people who often were not eligible for Medicaid, and that really changed that. So they had huge reduction in rates of uninsurance among single people, low-income people. So yeah, I agree. I mean, it's state by state. I don't know, could that change? Medicare for all? I don't know, we'll see. Something worth advocating for.
Yeah, Veronica, or Sean first and then Veronica.
Okay. I was wondering, like, in your presentation, you were talking about healthcare systems that all work together. And earlier we were talking about electronic health records, and how if one hospital or one medical system uses this type of record, then if you go to a doctor that uses a different type of record, they don't always work very well together. So if you think the answer is just one medical healthcare record for everyone, just one conglomerate company, or if it's just making the records more easily shared or more meshable between companies?
Yeah, no, that's a great question. They actually passed major legislation quite recently on interoperability, which is kind of like a policy wonky thing, but it's really, really important, which is trying to make healthcare records talk to each other. yes, I think there's so much money in this. I think it's very unlikely that you'll be able to get to say it's just going to be one uniform healthcare system, because it is really being driven by the market. But I think you can set federal standards to try and have these healthcare records talk to each other. And then there've been state, New York State has come up with several sort of initiatives to try at least have regional hubs where they all talk to each other. But I agree, that's the fragmentation, the sort of embedded fragmentation has really shown up in terms of how these EHRs and all these different companies, Epic and this and that. But I have to say, the National Health Service, in the UK, they still struggle with their electronic health record, even though they do have a uniform system. So electronic health records are hard, but it's certainly, the fragmentation is really difficult. And you deal with that, as frontline providers, you deal with all the hassles of the EHR.
Veronica, you had a question?
I do, yeah. And I don't know if this is like a question with a simple answer, but you had brought up the sort of looking at a policy level at the Affordable Care Act and the mandate and how that was like healthcare being mandated. Can you go into a little bit for us why that being removed makes it less effective? I guess I just don't quite understand like the benefit of the mandated part of it. So thank you.
Yeah. Well, there was, there was a lot of thought that went into that mandate. And it's basically the idea that will you buy insurance if you don't think that you're going to get sick? Yes. So healthy young people, unless they're forced to, will tend not to buy health insurance, which means that everybody who buys the health insurance is older and less healthy. And so you have a pool of high-risk people, which will push the premiums up. Because you really, really want the healthy people in there to spread the costs. The whole idea of insurance is that you spread the cost. So if you give people an opt-out, you've got a problem. Even with the penalty, lots of people, well, not lots, but quite a surprising amount of people didn't choose to get health insurance, even when the penalty was there. And then it's also the issue that if you take away pre-existing conditions, which they did, you can't be denied on a pre-existing condition, then you won't take out insurance until you get sick. Yeah, so they said it was kind of like until your house starts burning, then you take out the fire insurance, which is not how insurance works again. So that was all the thoughts, that it was absolutely vital to have the mandate. But having said that, the whole system has not collapsed without it. So, which has been interesting.
All right, so I think, let's see, it's almost 11:15, so you've stayed an extra 15 minutes, which we're very grateful for. Thank you. Just thank you so much for sharing your wisdom and your knowledge with us. And it's been very exciting, and we're going to put this on our YouTube channel so that others can also benefit from your experience and your perspective. And just again, thank you so much, Victoria. It's been a delight to have you with us this morning. And I'm going to put up my hand clap again.
All right, well, it was great, thanks. And, continue this amazing work that you're doing with the HRSA grants, and really impressive. So great to see you all.
We're trying. Good luck we're trying to get another grant at the moment. So let's
you said, yeah.
You'll be one of the first to know.
Yeah, cool.
All right, thanks so much.
Take care, everybody. Bye.
Bye-bye.